Qualcast Nation, welcome back. We have a very special guest today, fellow Ottawanian, or whatever we call ourselves from Ottawa these days, Walter Robinson. And we're going to talk about pushing the envelope in healthcare. And I think the lens will be, at least initially, about leveraging AI. So, Walter, welcome to the podcast.
It is a pleasure. I'm excited to be here with you on a snowy day. I had to change my backdrop. Didn't want to depress people.
I hear you loud and clear. So, tell us maybe a little bit about your background, how you got into the healthcare space, and what's exciting you these days.
My background is, long story short, Toronto boy who came to Ottawa to go to school, play some basketball at Carleton, because I was fascinated with public policy and politics. As a 6-year-old kid, I could tell you the prime minister, the premier, the mayor of Toronto, the local Etobicoke councillor. And I came to Carleton. And after getting my BCom, I've spent almost 30 years, although the LinkedIn people and the recruiters will tell you, just say over 2 decades. Don't date yourself too much. But I've spent 30 years at the intersection of public policy, Canadian politics, and the last 20 years, mostly in my career, except for a small virage detour as chief of staff to Mayor O'Brien for a year or so, in the pharmaceutical and life sciences space in Canadian health. Some of the things that I like to highlight are I wrote an acclaimed position paper on behalf of the Canadian Taxpayers Federation back in 2001 called The Patient, the Condition, the Treatment, which earned me and the CTF a coveted first day appearance before the Royal Commission on the Future of Healthcare. Have served in a variety of governance capacities in volunteer levels at the Ottawa Hospital Board. When it was the Board of Trustees, it's now the Board of Governors. I did a decade with the Ottawa Cancer Foundation, including 2 years as chair. Served on the Rehabilitation Center, and am still training, not fighting. But you may recall the Justin Trudeau Patrick Brazeau boxing match back in 2012. That's Fight for the Cure. I fought in that event 5 times because lots of people wanted to hit me in the head, of course. And now I'm the MC and producer along with Scott Whitaker, the CEO, and we raise over $1 million each year now for the net. 2 years ago, net, we grossed this past year, $1 million for the Ottawa Cancer Foundation to support clinical trials, research, cancer coaching. So I've been in and around the healthcare space and worked in pharma for a company, for a trade association, and as a consultant for the last 20 years.
Wow. So quite the resume. I don't know if you know this about me, but I was at that Trudeau fight, and my home gym was oh my goodness, I'm gonna forget final round.
Final round.
Matt and
Scott, yeah.
Scott, yeah, they're good people.
They're great guys, and it was always fun when I did it in 2000. The first time was 2008 against Terry Marcotte, who was the former anchor with CTV Ottawa News, sports anchor, and it was great getting hit by a guy 20 years younger than you sparring. And I remember we just, one small story, we're doing it for 3 or 4 years, and then my third fight, he says, "Walter, after 3 freaking years, you're finally moving like a boxer."
Oh, man. Yeah. And these days the training is that much more intense.
7 months these guys go through. Being an MC is easy. I just get to kind of drink a wine and write the script and talk to the fighters before and after the fights.
Absolutely. So I must say that what appealed to me, and the reason I reached out, was some of your comments on artificial intelligence in the healthcare space and where you see that going. So maybe first of all, when you think of AI in healthcare, are you excited? Are you doomsday? Where do you see some of the opportunities?
I am over the moon excited for its potential. And I took it up after being restructured out of pharma in 2020. I said, well, I can treat this as a defeat, or I can go learn and upskill. And the new thing is unlearn a bunch of things and relearn. So I did a lot of reading, a lot of webinars, as we all did during COVID. I mean, all of a sudden these conferences moved online, so you could participate with anything and everyone around the planet. I'm excited for it because it's a general purpose technology, and it can be used in so many places: climate change, materials science, healthcare. But the coalescing opinion, and we just saw this 2 weeks ago at the Consumer Electronics Show in Las Vegas, last week at Davos at the World Economic Forum, and the JP Morgan Healthcare Summit in San Francisco the first week of January, the applications in healthcare are becoming real. We've seen a lot of it, and you will have seen a lot of it in your role as a physician in radiology and a lot of the imaging specialties. We've seen a lot of AI already work there over the last decade to 15 years. But now we're seeing it in terms of people's apps on their phones. We're seeing it in terms of a lot of retrospective studies, or what you would call chart pulls, looking at 10, 15, 20,000 patient records and saying, is there a relationship between somebody's breath and how they respond to chemotherapy? Like, there's a variety of things, a lot of patterns that artificial intelligence and machine learning see that we as humans do not see. So I think there's great potential there, and I don't think people should be fearful of it. If I look at my phone, I'll just pull up my phone real quick. If I look at my phone, and everybody's got a phone, picture of my wife at the Senators game there as the screensaver. We've been training AI for the last decade. Your patients in the ICU, or people who are seeing their primary care providers or pharmacists, we've been training AI for the last decade on our phones in terms of everything we've been doing. Travel reservations, looking at our flights, Netflix, text generation, next words in those autofills. We've been doing it, and we're now at a scale because AI needs two things. It needs a lot of data, and it needs computing power, and that's where it really excels. And in that space, if you think about data, healthcare is the most data intensive sector on the planet. By the year 2025, it's just a year from now. I used to say 2 years, but we're in 2024. It will produce 36% of the world's data. And if you can mine that data appropriately with appropriate safeguards and privacy and a variety of issues we can get into around bias and health equity, there are some amazing things we can do across the discipline of healthcare, from primary care and keeping people and self-care, keeping people out of healthcare institutions, to when they come to the ICU or in the ER or in long-term care facilities. We can make things better for patients. And I'll stop on this one point, because we can't, and I've seen it in your book and some of your comments that you've done, we can't spend our way out of our current healthcare morass, and we can't hire our way out of it. The world is short of healthcare professionals across every discipline in every country. We need to think differently and not only think outside the box. I like to say think outside the building.
I like that. I like that a lot, actually. So, where do you see the biggest opportunities when it comes to these applications? Do you see it from like, certainly you mentioned it's already present in the imaging perspective when it comes to in healthcare. I'll see. I could see that also going into pathology eventually
Yeah.
for diagnoses. But do you see it in the being a solution mostly in the primary care, like the preventative care or in acute care? Where do you see the biggest bang at this time?
At this time, I still think it's in the imaging space. And I know everybody's talked about generative AI and chat GPT and these large language learning models. They're almost passe to a degree, and I'll come back to that in a moment. It is in the imaging space in terms of dealing with what it's called, I think Dr. Eric Topol, who wrote Deep Medicine, and other people have called the four horsemen of healthcare in the 21st century, in terms of cancer, cardiovascular risk, diabetes, and dementia, the most prominent being Alzheimer's, with our graying population worldwide. And in all those medical specialties, imaging is extremely important, from x-rays to CT scans to pathology. And I'm just not talking two-dimensional. We can look at ultrasounds. We can look at full motion video. We can see all those areas there, from your standard EKG to a full PET scan or low dose CT scan. There's a variety of things there where imaging can still work to help in diagnoses and be a companion to you and your colleagues as healthcare professionals, nurses, doctors, pharmacists, the allied health professions. And because I think in the next 2 to 3 years, there'll be two types of healthcare professionals: those who use AI as collaborative tools in their practice, and those who used to be healthcare professionals and aren't working as healthcare professionals anymore. And I should say something, I'm no AI expert, but I come at this as a consumer, as a guy who's getting up there, who has a chronic disease, who's been through clinical trials as a kid, and in terms of having our own child, and as being a caregiver to now two passed away but elderly parents. So I come at this from a consumer and a curiosity perspective, and I think that's what's missing in some of this debate, kind of taking some of the technologies and bringing them back to you could understand them at the kitchen table, like you and many of your colleagues did in COVID, talking about what the pandemic means, what the virus is, and what the societal implications are as well.
Yeah, I mean, I like what you're saying about having to embrace this. I do find already my colleagues are not ahead of the curve when it comes to the AI's potential and embracing it. And I I don't know how to say this kindly, but that doesn't surprise me in the medical space.
Well, I don't think, and it shouldn't. And you don't have to say it kindly. I don't think it's a pejorative or value laden value judgment about you or your colleagues. You're jammed right now in this post COVID environment with complex health conditions. We have the ER overcrowding. We have this triple demic of respiratory viruses right now this winter sweeping across Canada and parts of northern North America, and then. Uh, it's really come to a head in the last year or two, and your formative medical education really didn't provide you with anything in terms of algorithms, data science, and some of the medical schools are now getting to that, and they got to get to it quickly for the next generation of healthcare professionals. And then I think the other area is there is some sticker shock in chatting with my own, I shouldn't say culture shock, tech shock, sticker shock. We'll use those terms interchangeably. Chatting with my own family doctor about something that a lot of people have learned to understand, pajama time, in terms of clinical documentation. And a lot of people in the medical profession that I've spoken with, they're just like, is this another EHR, EMR quagmire where they may not talk to each other? And I still have a whole bunch of documentation to do with like what they call unstructured data, clinical notes. You may have your patient's blood work and urinalysis and some x-rays and other things, but then that discussion you have with a patient in a primary care setting or even an emergency care setting, you're making your clinical notes. And there's lots of stuff that you don't know, especially in an ICU capacity versus a family doctor. So what we're seeing is also, I think, helpful, but also dangerous, and with caution, is the use of generative AI, natural language processing, understanding generation, in what they call conversational or ambient AI, having a physician or healthcare provider having a meeting with their patient. And I use the term patient because when you're in the doctor's office, you are a patient, not somebody who lives with a disease or condition, because that confers a legal responsibility to your healthcare provider and your legal rights to you in that setting. Where you have ambient or conversational AI, where we could have a conversation about my symptoms, stomach ache, had drinking too much wine. I don't know what it is. You take some notes, and or you listen, and those can be transcribed almost immediately. And they can also go with what, as you know, ICD, or International Classification of Diseases, can be very helpful there. So doctors and for healthcare providers spend less time doing that clinical note stuff or prep at the end of the day or beginning of the day, and have more of this face-to-face time, which is what I when I've chatted with healthcare professionals, that's what they got into the profession. It seems to be the common denominator. I want to help my fellow citizen, and let's not kid ourselves. Healthcare is the most noble of human undertakings. I think it differentiates us as a species.
Yeah, the efficiency component is can't be understated. Like the amount of time, as you alluded to, family docs, nurse practitioners got to do towards documentation, what have you. I mean, even in our setting in the ICU or an emerge or in the acute care setting, the amount of time related to charting, whether you're a physician or a nurse, is daunting at times. And to have that capacity to be able to have that conversational AI spew out a note that reflects the conversation that you had with the patient, or to document all the important aspects of your interaction would be huge. It would be monstrous. And I know there's already programs that offer that, and what makes me excited is they're on paper only going to get better.
Well, let me give you an example. And in preparing for our quadcast today, I just started printing out stuff, and I'll talk about our Twitter, my X feed. I got to say X, or Elon Musk will get mad at me. I can't call it Twitter anymore. Um, in the United States, we have about 600 hospital systems. Some of these are big. They can be 20, 30 different sites serving populations of 500,000, a million people, right? Private and public. Epic, which is one of the biggest electronic healthcare records in North America, if not the world, they are now in 150 hospital systems with something called Nuance, which is part of Microsoft, and it is this conversational ambient AI helping to do documentation, helping to let a nurse practitioner, could be a pharmacist, could be whomever is in that care team looking at those components of the care patient journey through a hospital or through an institution during their disease, add those notes in, take a look. Yeah, that's correct. We can make a few edits there. It should be done always with patient consent, and then allows that qualitative components, those assessments of what you observed in terms of the patient was disheveled, the patient looked very tired, the visual cues were wrong, above and beyond the qualitative or the quantitative metrics of testing. That's very helpful. And it's helpful in, we're seeing some stuff. I read a few things this weekend about two things. One, where some of those patient notes in electronic healthcare records, and this is a retrospective study looking at what could be possible, shows clues, for example, of alcohol consumption that doctors have made notes about for their patients. And we know that alcohol consumption can provide post-surgical complications after a surgery, right? If there's a history of alcohol consumption, could be infection, longer hospital stay. That's what is being gleaned out of one algorithm looking at that. Another area is in social determinants of health. As we saw in COVID, we have primary care deserts, we've got pharmacy deserts, where racialized people or other people, low income, lack of education, you name those demographic, psychographic factors, can pull out from those clinical notes those observations that you don't see with the A1C score for somebody's diabetes, for example. That's the value of that kind of what they call longitudinal or over time relationship that a physician or a nurse practitioner has with their patient or patients, which helps to add that richness to any test data in the moment. That's the real power, and finding patterns.
Yeah, finding patterns and also allowing for more personalized health, personalized approach to health, which, in my opinion, is definitely the future of medicine, future of research. Because right now we still approach things with hey, there's this study showed aspirin's going to benefit the general population, and you're part of the general
Yeah.
population, so we're going to give it to you.
Well, and that gets you to that world of, I also sit on the board of the Canadian Organization for Rare Disorders in a volunteer capacity, given my background in life sciences and pharma. And when 1 in 12 Canadians lives with a rare disease, you're not like 15 or 20,000 other people who have the same condition. There may be a couple hundred of you in Canada, and we're at that world of precision medicine, personalized medicine. The irony is it takes the data of millions to help you get to the diagnosis for one, but artificial intelligence in healthcare can help you with that. And that personalized treatment is coming to more and more. People like to talk about a cure for cancer, and I always have the conversations with people. Do you know that cancer is roughly 250 different types of cancer with different genetic mutations, how they present differently? And we're getting to that world where a bunch of blood cancers and even some lung cancers can now be substratified as rare diseases. And you and I may have the exact same cancer, the exact same gene mutation, but we have a different genetic profile, different genetic makeup, different cultural backgrounds in terms, so we'll be treated differently. That's the beauty of AI in healthcare. And I've coined this, you've heard bench to bedside healthcare. I've taken it a bit further. I'm trying to get it to catch on. It's not catching on yet. I call it the 5 B's of healthcare. From bench to bedside to bumper, kind of like your neighborhood pharmacy is a great place for primary care, um, to bungalow, a lot of at-home testing. We've all swabbed our noses with COVID tests, and there's a variety of other things. Fecal samples for colon cancer, a variety of other things that we're doing. There's a whole bunch of new saliva box tests that you can do for certain diseases, and then being on your phone in the moment where you are now. So that's that personalization of medicine where the point of care is the patient. It's not the hospital. It's not the clinic. It's not the back of the ambulance with a paramedic. It's where you are. I mean, that's the exciting part of healthcare.
That is really exciting, actually, to think that we could get to that point. And I feel like in some ways, I feel like we're not that far away, but we are. And sometimes I do feel like we're pretty far away. And I know we were alluding to before how many of my colleagues we were slow to change. I'd argue, I still argue that it's to a fault. Like I often see even studies or data or evidence that are supporting a, a strategy or medication or an approach that for whatever reason is still not widely adopted or not globally adopted in intensive care units. And this is one of the few things that I thought was brilliant about COVID is that we were willing to change.
Yeah,
We were willing to be open minded and listen to the data that was in front of us.
but I think we're sliding back. If I think about telehealth, right, in terms of codes, in terms of that ministries allowed for telehealth visits, some of that has ended. And I used to joke, I grew up watching the Brady Bunch, and then for 3 years I lived it on a screen in front of me. And you can even do telehealth and dermatology to a degree. And some of the work that's happening in dermatology with resolution on images, and the FDA just cleared a skin cancer device 2 days ago or yesterday it would have been Friday. So I'm dating myself in terms of when we're recording. And but we were sliding back, or government policy is forcing that slide back. And then you see it as well, healthcare, and I know this in the pharmaceutical space and a bit from the medical technology space. We still have, and you've heard this before, we have an acute care system that is built on a 1950s, 1960s concept to a degree of healthcare. And I don't want to go to the Ottawa hospital unless I need to go there. Should be a whole bunch of other places, or sick. If your child needs sick kids, or your Jewish general, or wherever you need to be, if you're in the Mayo Clinic in one of the couple of the states where they are, you should only be going there for real specialty care. The rest should hopefully be primary care, which is 80% of what you need over your lifetime. Now, I will say that I will agree with you that the system is slow to adapt, and putting new technology on a very kind of top-down, institution-dependent structure is tough. I think there are two factors that we should consider, and where sometimes that slowness is important. The big tech world of fail fast and break things kind of doesn't work in patient care when people's lives are on the line. It's a little different. You need safety, you need rigor, you need health technology assessment standards, and you need to ensure that this algorithm that is on, we found a really cool algorithm that draws a relationship between people's breathing patterns and blood pressure and people who are getting treated for breast cancer and responses to immunotherapy or chemotherapy, and we can trigger and we can work on that. Okay, that worked for the 20,000 patients in one study. Were these people from a rich suburban hospital system? Does it work in a downtown setting? Does it work in a European setting? Does it work in South America, right? The replicability of some of these algorithms and technologies, they need to work across the board for patients mostly. And this is where we get into issues and some of the stuff I've been playing with around medical textbooks or clinical trial data. I'll be the first one to tell you, clinical trial data across the world, for the most part, is on clinical trials in patients who look like me, right? We don't have a lot of racial or genetic diversity in some clinical trials, partly because of social determinants of health, partly because where trials are done. Lots of times they've been done in metropolitan centers that if you're in a rural part of the country, you may not be able to get into that trial because the principal investigators are in major metropolitan healthcare institutions. That's changing, and AI can help some of that in terms of recruitment, patient-recorded outcomes. So there's a variety of things that we still need to get in terms of the regulatory and the governance component right. And just recently, 5 different radiologist societies released I think I would call it an opus on how to really drive AI in radiology forward and how it works with clinical workflow, how you educate radiologists, what is the return, how do we measure better health and patient outcomes, and how do we, unlike other technologies in the past, how is your framework agile enough? Because these algorithms, these deep learning neural networks, they continue to so-called learn with new data that is, because every new scan is another part of the training data, right? To kind of refines an algorithm or finds something new. And that needs a lot of thought and governance.
That's I'm glad to hear that there are groups now that are being proactive about many of these issues. So hearing about the 5 societies in radiology that are thinking about this, because yeah, I mean, you want to be ahead of the curve in terms of where your blind spots are, where how you're going to approach as new data comes about, because this is an extremely evolving field. And I mean, because and there's also the aspect of a lot of this is that there are some doomsday, there are like some legit concerns about how to interpret what's in front of you, and so I think it is wise, diligent to really be thinking about these things.
Well, I printed off, and the regulators I'm talking about, the Canadian, American, North American, European, and I think Australia and New Zealand, 5 radiological societies, put out a position paper, and it had a relevant information. It had a checklist. It must have, I'm looking at it in front of me, it must have about 50 different kind of components that you need to consider. It's like health technology assessment. So who's your company? What is the product? What is the imaging modality? Is there a target population? Is there an organ? What are the use courses? How does it work in clinical workflow? And then what's your product performance? Is your study design retrospective in terms of past just pulling, or do you have an actual clinical trial that you did and compared your new imaging technique versus the standard of care, for example? Was it a single or multi-center design? Is there software involved? What are your sample sizes? What were the training, the test sets? Is it in the cloud? Does it work with PACS, the old system that moved images around hospitals? Can you do it remotely? Can you do it on site? Like all these things that people have really thought about how the technology would work. What sort of training do you need? And what were your sample sizes? What number of sites? What countries of origin was it tested in? What sort of levels of regulatory approval do you have? And different levels of Health Canada medical device or FDA, they call it 510K clearance for medical devices. Is it just an image? Is it a video? Like, is it pixels? Is it voxels sort of thing? What kind of output are you getting? What is your pricing model? What is your technical support? Like all the things, like you would worry about. And has it been reviewed? Are they in peer-reviewed publications? Are there dissenting opinions? Is it open access? So they're really thinking about it, and that's really good because the speed of science, whether it be AI, medicine development, and before we kicked off chatting about all these other technologies. AI is just one of them. The omics, virtual reality, nanotechnology, synthetic bio, the Internet of Things, wearables, your Garmin watch or your Fitbit watch. That they're not. They can be variances in some of the data by up to 20% in terms of your heart rate and stuff like that. But we're getting to that space where we can have literally 724 365 passive monitoring of our vitals. And that can be helpful for when you are actually admitted to the ER, or you're in a multi-vehicle accident and there's trauma. There's a variety of things that can be helpful there. So going slow is important, and it's just finding that balance from a regulatory point of view, but also I don't want to call them pilot projects because Canada has so many pilot projects, yet we can never really get anything off the ground sometimes in healthcare and scaling up. And that's the other challenge of kind of getting these technologies to scale. A lot of people have, I've got a great imaging solution with AI for this type of tumor. Well, that doesn't help the radiology department when they're doing multiple scans for the cancer center or for ER or ICU or something else. So you need to kind of, there's a bunch of barriers to adoption there, and being able to scale these things up is one. And we're still in the early days. As much as the technology is fascinating, it's still the wild west out there of everybody has a tool, everybody has an algorithm. It's kind of like if you remember the dot-com bubble before the turn of the century. Everybody was pre-IPO. I've got an idea. I've got a technology. Well, most of them didn't last.
Far from it. Yeah. No, I mean, these are all good points, Walter. I'm curious, is there any other tech that is getting you excited within the healthcare space? Like, as we've been focusing on AI. Is there anything else that you think will, especially when we think about addressing some of our healthcare needs?
For me, it's still in its infancy, and I'm a sci-fi nut. I've always been a sci-fi nut, but we're seeing science fiction literally become reality before our eyes, becoming science, hard science. I've just seen a lot lately. With everybody read about generative AI, Chat GPT, inflection AI that has pi. I think I'll finish just on the AI
Sorry,
space.
inflection AI. Say that again.
Inflection AI has a chatbot called Pi, which is more conversational and more friendly.
Okay.
And then there's a company out of France called Mistral, which is an open source company that has some really interesting ideas here. I think the two things that in the AI space, there's still two things that excite me. One would be symptom checkers, and this is Dr. Google on steroids. That's what this is. The symptom checkers that you now have because ChatGPT and these other things, they were trained on the internet. Google now has MedPalm, which is a large language learning model, which is trained on medical databases. And they're doing some role playing with it to say that sometimes they're saying it has more empathy than doctors, for example, in helping clinicians or patients trying to understand their symptoms. I have on my phone, I've got a product called August. It's from a company out of India. I found it to be the best symptom checker that really goes in. You can even upload your blood results and it'll tell you what you're seeing in the blood roads in a PDF of what may have been missed. Again, always bring that back to your healthcare professional. It's kind of like, unless you're a doctor yourself, but even then, you probably want to have another opinion. So that's exciting. I think the other space that excites me is the robotic surgery, and infused with artificial intelligence. We're seeing that for remote. If you think about our communities, our Inuit and some of our First Nations and Métis communities, if you think about Iqaluit, for example, and Nunavut, the biggest cost of healthcare for those communities is transportation. It's getting to a facility to get care. And here in Ottawa, if people don't know, we are kind of the center of excellence for Nunavut in terms of healthcare when they need complex acute care in a metropolitan, fully functioning, state-of-the-art hospital setting. But imagine you can do remote surgery with the proper technology, 5G, 6G technology. And the other thing that's really fascinating, and I've read some studies, is nanotechnology. Nanotechnology in terms of breaking down, getting through the blood-brain barrier. Nanotechnology in terms of we have radio technology in terms of pellets that can be underneath the skin for prostate cancer. Imagine sending nanobots to do and combine that with cell or gene therapy and gene editing to attack a cancer before it presents itself 10 or 15 years before, to make those cellular repairs of the gene editing. So it's that microscopic space. And it's ironic, there's a guy named John Nosta who I follow, who's kind of a tech futurist, so to speak. And he points out that the three major inventions of kind of the civilized world, so to speak, for the last 500-600 years. One was the telescope that allowed us to see who we are and see beyond the scars. SARS. The second was the microscope to kind of take a look inside and see how complex we are as human beings, the physical biology. And now that AI is allowing us to look farther and look deeper inside. And the other one is what they call computational biology, which is part of AI, drug discovery. So many, as somebody who comes from pharma, the old way was it's kind of like find a needle in a haystack for a new therapy. Look at 10,000 molecules, see if one kind of works in a dish in a lab. Can we qualify it for human studies, work through a clinical trial? It may succeed, it may fail in getting to what they call endpoints. And usually most clinical trials, the endpoint is, can I reduce the severity of the disease or cure the disease, or can I extend life with degree disease-free progression? We're now at the space where many clinical trials will succeed. And then the question is, how do we pay for them, right? And that's the other big conversation that you've hinted at, that I think we need as a society, just not politicians or healthcare professionals or advocates, is how do we finance healthcare? We continue to look at it as a cost, not an investment. And I say this as a former Fiscal Policy Taxpayers Federation guy. When we look at so many other issues that are facing us right now, climate, we look at investments in electric technology and climate crisis, climate change technologies to help stop the warming of the planet. We're making investments that are 10, 15, 20 years out. When we think about mental health, a huge issue, we're talking about we need to change structures, we need to change workplaces, we need to change employers, we need to change societal attitudes. We're not looking at those investments as a cost each year. It's a generational societal change. A former health minister, a colleague of mine, Fred Horn, who was the Minister of Health in Alberta about 10, 15 years ago, says we need to have this conversation around how about lifetime? We look at what we put into healthcare and medicines over a lifetime. And I'm going on here, hopefully that's okay. If you think about gene therapy, some of the price tags for these could be $1 million, $2 million. But a gene therapy is a couple of treatments maybe, and there's lots of adverse events and lots of risks, especially in young children. But these people didn't choose to be born with a rare disease. So we shouldn't say it's an expensive therapy, because I think that's stigmatizing for their disease. But there is a cost to that. But then we have to say, but what would be the cost of that life lost if the gene therapy works and that person goes on for 20, 30, 40 years and founds new healthcare companies or a new technology? And we saw this with hepatitis C. We have literally, for the most part, vanquished hepatitis C. We've vanquished HIV/AIDS for the most part in terms of viral loads in the industrialized world, in the OECD countries. There's a different discussion around health equity in lower and middle income countries. But those things, for hepatitis C, the treatment used to be interferon, which is a very, very bad, it has a lot of side effects in terms of central nervous system issues where you take other medications, and then you may still need it, may have needed an organ transplant, a liver transplant, or kidney transplant. But now you have a therapy that can kind of solve your hepatitis C and take your viral loads down within 8 to 12 weeks. I mean, that has an in-year payback, and people are back at work. People are back teaching. People are back being parents. So that's the discussion we need to have above and beyond some of the, what I would call the artificial discussions we're having now around public versus private, Section 91 versus Section 92 of our Constitution. And I'd love to get into a bit of that if we have a little more time. If not, no worries.
Yeah, I think maybe we'll shelf that one for the next time we chat, Walter. But this has been extremely enlightening and joyous, because I love thinking about where we need to go in healthcare, and I think this conversation needs to be we need to be having more of these conversations to because
Yeah.
we're in a time of need right now. We need to be having these conversations so that we can start being proactive about many of these issues and serve the needs of our Canadians.
Well, think about healthcare. If you think about it as a sports analogy, do you want to win, tie, or lose? And I've said this, and I am deliberately provocative on these things. If you want healthcare sustainability, that's playing defense, right? That's not skating to where the puck is. And every system has a life of its own. If you want healthcare transformation, get outside the building, go on offense. Let's stop disease before it starts in a perfect world as much as we can. And let's have teamwork. You've talked about it in the ICU or any healthcare practice. It is a team. Everybody has a role. And we need more teamwork thinking in healthcare policy, healthcare system design. And again, going forward on these issues with some courage, and with patient safety and appropriate guardrails in mind. Absolutely. But fortune favors the bold, as the old saying goes, and we all want to live longer and live healthier. And doing the same old thing is not going to help us do that.
Amen. Let's start swinging the bat, yo. There's nothing wrong with that. Listen, thanks again so much, Walter, for joining us on the show. It meant a lot, and I have a feeling this won't be your first time.
I appreciate it. Last plug, AI_4 healthcare is my growing passion project on X, formerly known as Twitter, and I encourage people to follow and come along for this journey, because I'm learning every day, and I'm just trying to share it and make more people excited about it and get involved in the debates and the discussions.
I love it. Love it. Thanks for that, Walter. Thank you so much.
Thank you for your service and all you do for patients in this community.